Deep in the neck lies a diagnostic black box known as the parapharyngeal space. You cannot palpate it on a routine physical exam, and you cannot see it by looking down a patient's throat. It is an inverted cone of fat and connective tissue. The wide base starts at the petrous portion of the temporal bone at the skull base, and it tapers downward, terminating at the level of the hyoid bone. This anatomical diagram shows the inverted cone of the parapharyngeal space and the red flags marking its direct communication with the adjacent parotid, carotid, submandibular, and retropharyngeal spaces. Because it acts as a central anatomical crossroads, infections or tumors easily spill into it from surrounding areas. When you find a mass here, your immediate clinical task is determining which compartment it came from. When discovering an unknown neck mass, the standard clinical reflex is to order a tissue biopsy. In the parapharyngeal space, that reflex is a dangerous trap. Needles go in blind, navigating millimeters away from the internal carotid artery. The internal carotid artery is a major blood vessel that supplies oxygenated blood to the brain. Taking that risk is usually unnecessary because statistics show that 70 to 80% of tumors originating in this specific space are completely benign. The primary objective is to use imaging, rather than a needle, to differentiate benign masses from malignancies. This approach protects the patient from the severe bleeding risks of an unnecessary invasive procedure. The first diagnostic landmark to look for on a scan is the fat pad filling the parapharyngeal space. On a T1 weighted MRI, this fat appears as a bright, hyperintense signal. A T1 weighted MRI is a standard magnetic resonance imaging sequence that makes fat tissue appear bright white. The core rule of interpretation relies entirely on that fat pad. The direction a tumor pushes the fat tells you exactly which compartment the mass originated from. If you see a mass pushing the fat pad medially toward the midline of the throat, the tumor is coming from the lateral parotid space, most likely the deep lobe of the parotid gland. If the fat is pushed forward, anteriorly, the lesion is arising from behind it, in the post-styloid or carotid space. When the fat shifts backward, posteriorly, you can identify the mass as originating in the masticator space, situated in front of it. And if the fat is displaced laterally, outward toward the jaw, the mass is pushing in from the pharyngeal mucosal space. By mastering this fat displacement compass, a radiologist or surgeon can take a vague neck mass and pinpoint its exact local origin within seconds of opening the scan. Once you locate the mass, you divide the parapharyngeal space in half using an imaginary line drawn between the tensor veli palatini muscle and the styloid process. The tensor veli palatini, or TVP, is a broad, thin muscle in the head that functions to tense the soft palate. Drawing that line separates the front pre-styloid compartment, which contains salivary tissue, from the rear post-styloid compartment, which houses the carotid sheath and cranial nerves. The most common tumor found in that front pre-styloid compartment is a pleomorphic adenoma. These typically present as well-defined, tightly encapsulated salivary masses. To confirm a pleomorphic adenoma, look at the T2 weighted MRI signal, an imaging sequence highlighting water and fluid to make them appear bright. On these scans, the adenoma shows up as a bright white hyperintense mass. This MRI scan shows a post-styloid mass. Tumors behind the TVP styloid line are typically neurogenic, like the well-defined, oval, and slightly more heterogeneous neurofibroma seen here on the right. A neurofibroma is a typically benign tumor that grows from the Schwann cells protecting peripheral nerves. By simply identifying the TVP to styloid axis, you instantly narrow your differential diagnosis down to either a salivary origin in the front or a neurogenic origin in the back. You must also look for the most high-stakes post-styloid lesion, the paraganglioma or glomus tumor. A paraganglioma is a rare, highly vascular tumor that forms from certain types of nerve cells. These imaging panels show the classic salt and pepper hallmark of a paraganglioma. The salt refers to small bright foci of hemorrhage, and the pepper refers to the intralesional flow voids. A flow void is an imaging artifact where rapidly moving blood appears completely dark on an MRI. This digital subtraction angiography shows exactly why those flow voids appear. The tumor has extreme vascular density, causing a significant blush of contrast and physically splaying apart the carotid bifurcation to make room for its own blood supply. Identifying these flow voids on an MRI creates a clinical absolute. A biopsy is strictly contraindicated. Piercing this mass with a needle causes severe, uncontrolled bleeding. The salt and pepper pattern is a mandatory stop signal for the clinical team. It requires an immediate pivot away from a biopsy and straight toward angiography or surgical planning. Not all masses respect these anatomical borders. A transspatial lesion is a tumor that ignores fascial boundaries, aggressively encasing muscles like the TVP or invading the adjacent medial pterygoid muscle. The statistical reality of a transspatial finding is grim. Nearly 90% of transspatial lesions in this area are malignant, most commonly squamous cell carcinoma or lymphoma. Squamous cell carcinoma is a common type of cancer that begins in the squamous cells lining the mucosal surfaces of the head and neck. These scans show the clear imaging checklist for malignancy. You can see the irregular, ill-defined margins, a necrotizing mass invading both the parotid and parapharyngeal spaces, and accompanying nodal involvement. When a mass ignores the established compartmental walls of the neck, the diagnostic working theory must immediately pivot to cancer. For generalists, the takeaway is simple. If a mass pushes the tonsil medially, skip the CT scan. Order a multi-sequence MRI with contrast to safely rule out highly vascular tumors first. A multi-sequence MRI uses different radiofrequency pulses to capture multiple types of tissue contrasts in a single session. For radiologists and surgeons, the diagnosis maps to a simple matrix. Prestyloid and benign points to a pleomorphic adenoma. Poststyloid and benign points to a schwannoma or paraganglioma. Anything crossing boundaries into the lower half of the chart is transspatial and therefore malignant. The diagnostic hierarchy is strict. First, find the fat pad to see which way it's pushed. Second, identify the compartment using the TVP to styloid line. Third, analyze the MRI signals for T2 brightness and vascular flow voids. The parapharyngeal space is a predictable anatomical crossroads. Applying this structured logic replaces diagnostic uncertainty with absolute clinical clarity, ensuring safe and accurate treatment planning for the patient.